Hello, I like to present to you the endoscopic TEP release reinforced technique for sportsman hernia and athlete Pubalgia and the outcome of 461 athletes over 9 years of study. The technique of endoscopic TEP release reinforced technique for sportsman hernia I started to develop at 1997 and I refined it over the years while operating routinely on 1,200 athletes. The last 10 years and 461 athletes were examined by surveys that we did, and the results are very promising because 98.5% of the athletes returned to sport activity. All the group of the patients that were operated were 461. They are divided in two groups. 447 were primary sportsman hernia and athlete pubalgia, while 13 of them were recurrent sportsman hernia and athlete pubalgia that were operated in another center. All the patients underwent athletic muscle rehabilitation program. The first group, it's take to them between 6 to 12 weeks to complete the program, while the second group of the 14 patients with a recurrent hernia, they were faster and they completed in 8 weeks. Now, from these 14 patients, after the completing the program, all of them, all the 14, returned to sport activity. On the other group, the first group of 447 primary cases, 396, after completing the rehabilitation program, returned to sport activity. But 44 of them needed some more treatment, and because of that, it go up to 12 weeks. And from this, 4 were not able to return to sport activity, and 2 had some hip problem later on, we realized. But 38 of them returned to sport activity. There was another group of 7 patients that has postoperative complication, but 6 of them, after treating the complication, completed the rehabilitation program and returned to sport activity. So only 5 altogether didn't return to sport activity. So that brings us to 454 patients return to sport activity, that it brings us to this 98.5% success rate of return to sport activity. The endoscopic TEP release reinforced technique has 2 phases. The first phase is a release phase to release all components that creating the damage to the pubic bone and the posterior wall, including dividing the inguinal ligament that entrap 3 nerves that's scoring behind of it. And we can see in the left picture that after completing the releasing of adhesion from the pubic bone, we are going and we're dividing the inguinal ligament in the point of the lateral side of the inguinal of the internal ring, and we can see very nicely that there are 3 nerves that's scoring behind of it: the genital branch and the femoral branch of the genitofemoral nerve, and more lateral, the lateral cutaneous nerve. And the second phase, after we're completing the release, it's the reinforced phase that reinforce all the posterior wall with mid-weight wide mesh, and we glue it with Fabian glue. The procedure it means total extraperitoneal, so we see the adhesion in the extraperitoneal space, it's cocon adhesions that you can see here that we divide them, and then we coming to the pubic area, and now we can see it very nicely. And we see that there is posterior herniation of the disc in the symphysis. And beside of that, we see also the neovascularization that we are burning them. And those are results of the inflammatory process of the pubic bone. So we have to burn them with all the nerves ending that coming beside of them. And then we dividing the adhesion on the rectus muscle. And here we see a more severe case of athlete pubalgia. And this is a grade 5, where before it was grade 4. And you see much more adhesion and inflammatory process because of bone marrow edema and stress fracture of the pubic bone. And so we are cauterized all of them, and we burning, and then we release, as you see here, we start to release the adhesion of the rectus muscle to the pubic bone. The next step is to release lipoma that are incarcerated in opening rings, like here in the inguinal ring. It's happened in 90% of the patient because of the relaxing of the abdominal wall. So it's coming herniated by lipomas that have to be extracted. Here we can see what it's called the bulging of the posterior wall. It's very prominent in the Sportsman Hernia because of the disruption of the posterior wall. And we see that opening of the internal ring and the Hasselbach, and we see that the inferior epigastric vessels are not attached because of the relaxing of the posterior wall. And here we can see the Cooper ligament, and it's far away from the Hasselbach, and we see it again. The Hasselbach is far away, not connected well to the Cooper ligament, and this is the posterior wall, the disruption of the Sportsman hernia. The next steps, it's like in any hernia repair, we have to skeletonize the cord element. Here you see the vas deferens and then the vessels. Always there is a small hernia sacs that have to be separated and divided back to the peritoneal level. And we can see here on the left side the lipoma, right side the lipoma that we dissected before, the preperitoneal lipoma. Now we are coming to the most important phase of dividing the inguinal ligament. We have here a case of chronic fibrotic area. So the dividing here, it will be slowly. We see that we hold with the left hand the inguinal ligament, the iliopubic tract, and the right hand we use the electrical hook, and this is the level in the level of the inguinal ligament, the internal ring, and we are dividing the inguinal ligament face by face up to the end of that, and then we shall get the two sides, and we shall see it immediately separate, completely separate, and we inject Depomedrol between them to prevent readhesion. As the next picture, you see here more acute phase, and here we can see the nerves, the genital and the femoral branches of the genitofemoral. And here we are dividing the iliopubic tract, the inguinal ligament, and it's not fibrotic, and you see that it's more edematous at the end of the dissection here. And we go to the other side, always it's bilateral, and you see here even a tubular degeneration of the inguinal ligament with the fluid inside the generated inguinal ligament. So again, we are dividing it to the bottom to complete dissecting all the ligament. At the second phase of the procedure, as I mentioned before, we reinforce all the posterior wall with a mid-weight mesh, And here we apply it. You see it's a double scroll that we roll the mesh. And then after spreading the middle part, we fuse it with a fiber glue. And we are not using a tacker, not to irritate the wall like for Sportsman Hernia. It's very important. So after gluing it with the fiber glue, the middle part, we spread the lateral part of the dual scroll, and by that we complete the spreading of all the mesh, and then we can go and fuse the lateral part of the mesh. You see the upper part first, and then we use the fiber glue to the lateral. At the end, we can fuse and spray the lower part, that we cannot use it with a tacker because of nerve and vessel, but using fiber glue, we can do it in this place. Always bilateral damage, and so we always do the same repair on both sides. And so after we completing, we use the same mesh and just we overlap it on the center. And again, we use the fiber glue to fuse it, and then the upper part and the lateral side, as we did the other side. And after we complete it, we go to the lower part, and then we fuse the mesh to the vessels and the floor on the lower part. We complete the procedure by introducing Jackson Pratt a closed system drain that for a few hours. This is very nice ways to do because it's collapse the space and fuse the peritoneum to the abdominal wall. To conclude, I can say that the surgery and the results are very promising. Thank you.